Good afternoon, everybody. Before we begin, I would like to let everyone know that this session is being recorded. These recordings will become available on our website post-session. We are very excited to have all of you join us for the 15th Dent Echo. My name is Kato, and I will assist in facilitating today's session. For those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. Some notes before we get started. Please stay muted unless you're speaking. You can also use the chat to raise questions and share your perspective. Please remember that no personal health information is allowed in either the chat or our discussions. And to help with attendance, please enter your name, affiliation, and email into the chat. And if you would like any assistance with your connection through the session, please chat Tori, our Dent Echo IT. These sessions are enabled for closed captioning. If you would like to view captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option in the More menu. And to receive CDE credits, registration is required through the UT Health CDE website, and also you would need to be on the session throughout the duration of the presentation. We will also follow up by email with the instructions for completing the post-session evaluation and attaining your credits after session. If you haven't already completed the pre-session questionnaire, you can do this now using the link I believe Tori will be sharing. Yes, thank you, Tori, in the chat box. Also, we are always looking to recruit more case presenters. If you have a case you would like to share with the Dent Echo Network, please let us know. And ECHO is an all-teach, all-learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage everybody to participate in the conversation today. We also encourage you to join by video if you can, especially during discussion portion of the session. Our session today will include a didactic presentation from Dr. Marwaha on opioid addiction and pain management in dentistry, and a case presentation. In the spirit of all teach, all learn, we encourage you to share your experiences, questions, and perspectives. And with that, we'll move on to introductions. Dr. Challa.
Thank you, Kito. I'm Suman Challa, Associate Dean for Advanced Education Programs at UT Health, and want to welcome all of you all, and thank you for taking the time to attend the session.
Thank you, Dr. Challa. Dr. Dar.
Hello. I'm Shohini Dhar. I'm an assistant professor with the Department of Comprehensive Dentistry. Welcome to today's session.
And Kathleen.
Good afternoon and welcome. My name is Kathleen Weeks, and I'm very excited to be part of Dent Echo. I am the co-director and the project coordinator here at the School of Dentistry.
And then I see our case presenter, Dr. Rankar, is able to join. Are you able to unmute and introduce?
Yes, definitely. I am very excited to be here presenting this case today. It's a very interesting topic. My name is Dr. Yashashri Urankar, and I am the Chief Dental Officer at a community health center. And so the name is Community Health Centers of South Central Texas.
Thank you. And Dr. Marwaha, please introduce, and when you're ready, please share your slides and take it away from there. Thank you.
Thank you, Kito. Hi, I'm Dr. Rajisha Singh Marwaha, and I am also on the Hub team. That's why you see me quite on and off, but today I will be presenting a little bit different than what I usually do, and I'm excited to share whatever I've learned over the years in terms of opioid addiction and how to manage acute pain in dentistry. Let's share. I'm going to share my screen, so and if you have any questions, we will have time after my presentation to discuss it, and I can answer those for you. I will not be checking my my chat during the presentation, so if you have any questions, you can also put it in the chat. All right, are you able to see my screen? Okay. Great. Let's get into it. Again, everybody who hasn't who just joined, good afternoon, everyone. We're ready for our July Dent Echo session, and we're going to get into talking about substance use disorders, but specifically opioid addiction and how it relates to dentistry. So substance use disorders have devastating consequences, not only on the patient, but also they negatively impact their families and loved ones. Deaths from opioid overdoses, they have increased due to a result of overprescribing and illicit drug abuse in the past several decades. The surge of opioid overdoses in 2017 prompted the US Department of Health and Human Services to declare it an epidemic in 2017 again. Based on the recent CDC reports, each day 187 people die from opioid overdoses and mortality, and this has quintupled over the past few decades, 1999 to be specific. In dentistry, we are prescribing opioids frequently to manage pain, following both acute and chronic pain cases. But for the purposes of the presentation, I will only focus on acute pain management. I am just trying to adjust my camera because I would like to focus on my slides. All right, I'm ready. So some of the learning objectives, and if you read the flyer, these were mentioned there. So this session will typically talk about opioid epidemic in the US and the dentist's role in identifying and addressing signs of prescription opioid abuse and in their patients, and using non-opioid alternatives for pain management. This session is intended to motivate participants to take action against the unnecessary prescription of opioids. Here are some of our learning objectives. So we will be identifying signs of opioid use and abuse in our patients. We will learn how to educate patients about the risks of associated with leftover opioid doses. And we will also understand the best practices and implementing these evidence-based practices for acute pain management following dental procedures. Okay, so I wanted to start up with a little bit introduction and giving you a background on what's been going on over the years since I've been involved in this topic for several years. I've had a chance to dive deep into the history of it. So as I mentioned before, the opioid crisis was declared in 2017. That was 2 years prior to COVID. And in COVID-19 that hit towards the end of 2019, that had created a devastating collision of health crisis in the US. Based on the American Medical Association, they said that the nation's COVID pandemic made the drug overdose epidemic worse. And it had crossed, the COVID pandemic had crossed all borders globally and needed immediate attention, which kind of took away the limelight that opioid addiction and opioid overdoses and mortality had gotten in the previous years. But this did not really disappear. It obviously disappeared from the news, but in reality, in fact, got worse. And why did that happen? Because there was a surge in mental health problems as a result of an economic shock, social isolation, and there was increased mental health distress due to disruption of addiction support and anything that required face-to-face visits, because at the time we we were isolated and we did move to virtual platforms. We were all aware that there is an association between mental health disorders and substance use disorders, and this led to fearing that the pandemic would produce conditions even more worse, which was actually realized when CDC's preliminary reports on overdoses came out. These are some of the statistics that I have. These are the most recent that are published out there. So 2019-2020, the number of drug overdose deaths, they increased by nearly 30%, and 75% of the approximately 92,000 drug overdose deaths in 2020 involved an opioid. This is again based on CDC data, which I'm going to use for quite some topics in the presentation. Now, moving on, I wanted to show you the numbers and the statistics to really understand the issue behind it and why it is so important for us to learn about this. Based on the Health and Human Services report in 2019 that you see on your left, nearly 70,000 people in the US, they died from drug overdoses, out of which 48,000 were attributed to opioids. And then the other number that I would want you to focus on is that 1.6 million people died of an opioid use disorder, and this number is increasing as we speak. 10 million people misused prescription opioids, which is something that we are concerned about as prescribers of opioids. The Centers of Disease Control and Prevention, again, as I mentioned, these statistics previously, 187 people die every day of opioid overdose, and 75% nearly die of drug overdoses that involve opioid, both prescription opioids and illicit drug abuse. Now, CDC estimates the economic burden of prescription opioid misuse in the US to $78.5 billion. And that includes costs of healthcare, lost productivity, addiction treatment, and criminal justice involvement. We've been talking about opioids, and so I thought it would be good to just give a little bit background on this class of drugs. So opioids, they are derivatives of opium poppy plant. I have a picture on the background, and I'm sure a lot of people may have had poppy seed bagels, so you know what that looks like. These are referred to as narcotics sometimes in both medicine and dentistry. And these drugs, they contain chemicals that produce pain relief, which is the primary reason we prescribe in medicine and dentistry, but also it relaxes the body and induces euphoria. The inducing euphoria effect, that is the main reason why people start using or misusing it. The most commonly prescribed, or just the most commonly used opioids in practice are morphine, prescription opioids, we have fentanyl, and then heroin. Heroin is an illegal street drug. This cannot be prescribed, but the other three, they are prescribed for different procedures depending on the need and, again, the severity of pain. Morphine is a natural opiate. Prescription opioids, we'll get into it a little deeper in the upcoming slides, but you may have heard of oxycodone, hydrocodone, and then we have acetaminophen, codeine, combination Tylenol 3, which we are more commonly prescribing compared to the other two I talked about. Fentanyl, again, prescribed. It is a highly controlled substance, even higher than the prescription opioids that I just talked about. It is 50 to 100 times more potent than morphine and usually used for, advanced cancer stages and patients who report that. All of these substances are highly addictive, and they could lead to overdoses and death. Again, if misused or abused for a certain period of time and very frequently. For the same reason, the Drug Enforcement Administration, DEA, has classified most narcotics as type 3 and type 4 substances. So they only a licensed healthcare professional can prescribe it, but also these have a very high potential for abuse and misuse, and that's why they are type 4 and type 3. Type 1, just so you know, type 1 has the lowest potential for abuse, and type 5 would be the highest. All right, here are some long-term and short-term effects of opioid use. But just before we go into that, I'd like to give you a brief, how these opioids really work on humans, or basically works on the brain, on the central nervous system. So the opioids, they bind to the mu receptors that are located in many areas in the CNS, the central nervous system, primarily brain and spinal cord, but also other organs in the body. and they are involved in feelings of pain and pleasure. So block pain, and then again, they produce a lot of dopamine, which eventually leads to, getting feelings of pleasure. This release it can strongly reinforce the act of taking the drug again and again, so that the user can experience the same feelings of blocking the pain and experiencing pleasure over time. Some of the short-term effects include pain relief, which is our primary reason of prescribing it. It does cause, relaxation. So we have drowsiness, and it is associated with euphoria. Again, we are going to go into the other long-term effects, but some patients could experience constipation, nausea as well. Slow breathing is one of the side effects as well that a majority of the people experience. Regular use can increase your tolerance levels and your dependence on the drug, and it requires more frequent doses and a higher dose to get the same euphoric effect. So the user would want to try to obtain the drug more frequently, and again, a greater dose, a higher dose. Some of the long-term effects, they include opioids that can they restrict your ability to breathing, right? We talked about slow breathing. What happens due to that is the oxygen supply to the brain is cut down, which we call hypoxia, leads to respiratory depression and subsequent death if the patient is not revived by an antidote, which we usually use naloxone to revive a patient who we suspect is overdosing. So here are some brain scans that I found, and this really just shows the differences between a healthy and an addicted brain. And the red illuminated parts of the brain signify that they're comparatively more in the healthy brain compared to the addicted brain. So this is just, how I interpret it is that it does change your brain and how it functions to a great extent if you were taking it consistently and over a prolonged period of time. Prescription opioids. This is, again, a part of the class of drugs called narcotics that we talked about. And for the rest of the presentation, we're going to be focusing on prescription opioids. Prescription opioids, we usually prescribing them to treat moderate and severe pain. Most commonly prescribed ones are hydrocodone acetaminophen combination, Vicodin, oxycodone, and acetaminophen, again, combination Percocet, and then we have morphine, and I talked about the acetaminophen and codeine combination Tylenol 3 already. So those are the top ones that we're using. Tylenol would be, I would say, the one that's most frequently prescribed, Tylenol 3. These drugs are safe to be prescribed for pain relief when taken at a low dose and a very short duration of time, as prescribed by the doctors, and while within the bounds of what's really the best practices of the ADA and the CDC, which is something that we're going to talk about a little bit in detail in my upcoming slides. All right, before we get into that, I wanted to kind of define what prescription drug or prescription opioid misuse and abuse entail. We may understand a majority of it, but some aspects of it, you may not be aware that is considered misuse. So this is, again, from the SAMHSA 2019 data. And if you see 50% of the people got the prescription medication from their relative or a friend. And then the second highest was getting prescribed from a prescription from a doctor, a healthcare provider, or stealing one. So some of the people have reported, or some of them have been stolen from a healthcare provider. Some of them actually got it from more than one providers, which is also called doctor shopping. So for the same issue, you would go and see multiple providers just to procure prescriptions. Now, stealing prescriptions was, I would say, a thing of the past because we have, switched to using the PDMP for prescribing, but I'm sure there are some individuals who are still practicing, the traditional way and having notepads. So that's something we need to be aware of. And then approximately 6% they were able to get these drugs from a drug dealer. Now, just a little summary of it. So what entails prescription opioid misuse is taking the medicine in a way that is other than prescribed. Then taking a medication, someone else's medication, taking a medication for its euphoric effects, and then finally taking the medication or procuring it for either drug use or drug diversion. A hypothetical story I can come up with about this is, say, an older adult has, was prescribed some pain tablets by a physician after knee surgery. And this individual seems to get relief from the first 2 tablets that they took, and they did not really store it or dispose the remainder, right? They have a granddaughter who, out of curiosity, found those tablets in the kitchen cabinet that was unlocked, and now she wants to experiment with it. So that would be misuse because she was not prescribed, she's taking someone else's medication. And then she experiences euphoric effects, takes another one, eventually that could lead to addiction. Also, because she experimented and she liked it, now she wants her friends to try it. So that would be an example of drug diversion. So now the older adult who may actually be in need of this medication does not have that, and this prescription medication is going somewhere else which shouldn't be. Okay, so some of the consequences of opioid misuse. So of course, we've talked about how it could lead to an opioid use disorder and addiction. And this happens when you're repeatedly misusing the drug. Addiction could vary in forms, and the most severe form is called substance use disorder, where it changes your brain and you will start experiencing a difficulty in fulfilling your responsibilities at work, school, and also at home. And if the person addicted to the opioid medication tries to stop it, they will experience withdrawal symptoms. So symptoms may include bone, muscle pain, sleep problems, nausea, vomiting, cold flushes. They will have uncontrollable leg movements and severe cravings, and they would want to go back to taking this substance. The next one of the most important things as a consequence is the switch to other synthetic opioids. So why this is important is because a majority of studies have seen that about 31% of dentists are prescribing to individuals who are 10 to 19 years old, right? So adolescents and young adults. And these are more likely to be opioid naive. So that means they are using opioids for the first time in their life. Now, what happens, it is hard to go back once you're addicted to go back to a healthcare provider to get those substances. And I was a little curious, so I found out that how much it really costs. So once you're not able to get your prescriptions from a provider, you would like to get it from elsewhere. And Vicodin costs $126 for 100 pills without insurance when prescribed by a healthcare provider, which means it's about $1.26 per tablet. And one tablet on the street costs $5, which is 4 times more. However, that's when they start switching to heroin because it produces similar euphoric effects. And that costs way cheaper than getting the prescription drugs. So that's how a lot of individuals or young adults may go down that route and start seeking other synthetic opioids, which are much more dangerous and are more often associated with overdoses and mortality. Then next, we have increased high-risk behaviors. So, there's a risk of communicable diseases such as Hep B, Hep C, HIV, especially if any of these opioids are misused intravenously or abused intravenously. Again, very risky driving behaviors. We're all aware of that. Then we know about the drug-related crime, drug overdoses. A lot of the drugs, street drugs, are laced with fentanyl. That was a recent report which has led to even more overdoses than the previous years. And finally, death. So here is some data that I was able to get for our specialty as dentists. So dentists are the second highest prescribers of opioids after internal medicine. And we're prescribing approximately 9% of the total opioids. Dentists, they are the leading source, as I just said. They are the leading source of prescriptions in children and adolescents, which is really exposing the opioid, a large number of opioid naive patients to opioids. 75% of the dentists, opioid prescriptions, they are new starts. And this includes individuals who have not ever had an opioid prescription filled in the past 6 months, or who have not been priorly exposed to any opioids. Studies have shown that the age group that we're discussing here, which is 10 to 19 years, they are very vulnerable to substance use disorders and more likely to result in long-term abuse compared to someone who may be 35 years of age and had not had a prior experience with opioids. Then 59% of the prescriptions are filled following oral surgery procedures. We know that they can be a lot more invasive, so that if the number is very, very high, 60% approximately. And then a randomized controlled trial revealed in 2016 that 54% of the opioids prescribed for dental surgery procedures were unused. So this is where drug diversion comes in, right? Or misuse potential comes in. I was reviewing and I looked at this study from the University of Michigan. This was conducted by Dr. Chow, and they did an analysis of claims data from 2011 to 2018 for publicly insured patients ranged 13 to 64 years of age. And they were trying to explore connections between dispensing opioid prescriptions after dental procedures and the 90-day risk for overdose in the patients. So here were the top 3 findings that I'm sharing with everyone. Filling opioid prescription after dental procedures was not only risky for the patient, but also their family. And I think that's kind of a little bit clear from the hypothetical situation that I presented with in the previous slides. And then nearly 27% of the teens and adults were filled an opioid prescription. And I think this one is the most significant, which answers their research question that 2,700 opioid overdoses, they occurred within 30 days of dental procedures. So that is a big number and seems to be generating some concern there. All right, another study that is very interesting for us before we go into how do we combat this epidemic is a study that was published in JAMA. This study talks about the efficacy of prescription opioids for dental procedures, specifically for acute pain. So some of the study findings were that patients who were prescribed opioids reported higher pain following procedures. And then patient satisfaction was similar for both opioid and non-opioid groups. So the patient really didn't have a higher or higher preference for opioids. And then the One of the other important ones, one was the 50% of the prescription opioids that were prescribed, they were not used. So they were basically not needed by the patient for pain. And then again, that brings us to the place that this amount of prescription opioids were open for drug diversion. All right, moving on to the second part of my presentation, which is how we as dentists have a role in combating the opioid crisis. So these are, I would say, the 5 main things that everybody needs to keep in mind. You need to be able to identify the signs of opioid use and abuse in your patients, educate your patients about the short-term and long-term risks of opioid use and drug diversion. Manage patient expectations, implement evidence-based practices by the state licensing boards and the ADA for acute pain management, and always know your best practices for prescribing opioids. Now, we're just going to go into details a little bit for each of those. For identifying signs of misuse, it is very important for you to know patient's substance use history. So you can ask patient the medical history, dental history, social history can give you a lot of insights into other substance use history. So for example, if a patient has a history of alcoholism, more or less likely they could also be having an addictive personality. That means they could be using other drugs in combination with alcohol. So it's very important to get a thorough understanding of that. Then the next thing is we always need to screen our patients for opioid use disorder. So one of the really good ways to do that is history taking, like we talked about. So you want to see what other medications are the patient is on, anti-anxiety, narcotics, anything else that could really give you an indication of this, maybe, bring that suspicion so you could take care of this patient a different way than you usually would. And then very important is checking the PDMP. So that's the prescription drug monitoring programs. All states have one now, and it is very important to check before prescribing to see for what and who prescribed the medications to the patients. Again, it also tells you about the dose prescribed and the frequency. So you will be able to get an idea if the patient really needed it for pain or were they seeking drugs. And then finally, you need to be able to identify the red flags in addictive patients. So we talked about doctor shopping. So for the same illness episode, you would go to procure drugs from several providers. The other one is switching, history of switching providers. So if one provider is not prescribing, you would go to another one. And then the next one is requesting a specific medication. So a lot of the times what I've seen in the past is patients will come in either Friday afternoon because they know that Saturday, Sunday, you're not going to be open, try to get the procedure done. The minute you say, let's get started on the procedure, they'll be like, okay, no, I don't need the medication. I just need the medication. I'm in pain. We can do the procedure later. So they won't let you get started if it's an RCD and if you want to do a lumpectomy. The other thing that I've noticed is they would say, I have allergies. I have allergies to ibuprofen, codeine, everything but an opioid. And then they could request that, okay, hydrocodone or oxycodone or Percocet work best for me. So can you prescribe that? So those are some behaviors you need to be mindful of. What can you do as a dental provider? So it is very important for you to take training courses on addiction, keep updating your knowledge, take CE courses. That's very important. Then the second one is address addiction and unhealthy substance use in an open and non-judgmental manner. Provide resources and referrals if you see your patient is struggling and has an addiction disorder. You could provide referrals for treatment. And offer prevention messages, especially in the younger age group, so the 10 to 19 teens, adolescents, younger adults. Prevention is always better than cure. And one of the other things that you can do as a dental provider, if you need to have a baseline and watch and observe your patient for any changes, recognize behaviors and changes over time. Dental hygienists may be a great source for that because they do spend a significant amount of time with the patient and they have that opportunity to talk and build that rapport with them. All right, the next is educating your patients. So I have this little slide where I kind of combine everything that needs to be done when you're talking to your patient. You need to be able to manage patient demands and expectations and not feel pressured to prescribe an opioid for this sake of, oh, I would lose a patient, or, for example, it's a threat to my practice. Patients usually will understand if you give them more information. So share data with them. I think that would be really good with managing some of the concerns that they may have. Then again, talk to them about the efficacy of non-steroidal anti-inflammatory drugs, NSAIDs, which are proven to have better efficacy for acute pain management because they reduce inflammation and not just combat the pain like opioids do. You need to talk to them about the short-term, long-term effects of opioids, something that we have discussed before. You also need to make a decision at that point. If you are prescribing, you need to talk to your patient about safe storage of medication or disposal of leftover medication so that it does not have a chance to be diverted. And then we need to educate them about the risks of leftover medication, and that kind of ties into our fourth point of addressing how to safely store and dispose the medication. So here are some clinical practice guidelines that I was able to get. This is an updated guideline from the CDC. They published their initial report in 2016, and they just updated it in 2022. We follow it. All dentists are supposed to follow and keep up to date with the guidelines whenever they're updated. So I have some presented here. They are mainly focusing on 4 areas. So the first one is determining whether you want to initiate opioids. The second one is you need to select which opioids to prescribe and for what amount of time. Determine the dosage. The next is once you've decided that you are going to prescribe an opioid, you're going to prescribe opioids, you need to conduct a follow-up. And the last one is you need to assess risk, and if you do see signs and behaviors that indicate that the patient is dependent, what are you going to do about it? So I don't intend to overwhelm you with this text-heavy slide, but I still wanted you to see what those guidelines are. And I will have a link to the resources in the last slide, so feel free to read the paper. But I have summarized these 12 recommendations that CDC had. They're really focusing on a couple of points that I'm going to go over very quickly here. They want us to maximize the use of non-pharmacologic and non-opioid therapies and consider opioids only if they outweigh the benefits for our patients. Whenever we're prescribing, we need to go in for immediate release opioids and not extended release. For opioid naive patients, if we do plan to go with the dose, it needs to be the lowest effective dose and also for the shortest duration. Patients receiving an opioid therapy, they need to be able to outweigh the benefits and risks if they're planning to change the prescription dosage. So if you're planning to increase or decrease, again, you need to revisit the benefits and the risks. For acute pain, clinicians, they need to prescribe no greater quantity than needed for expected duration of pain, severe enough to require opioids. Again, if you are prescribing, you need to conduct a follow-up and make sure your patient is doing okay. It would be great if you could discuss strategies to mitigate risk. For example, you could offer naloxone to be able to reverse an opioid overdose just in case. And then when we're prescribing initially any kind of opioids, we need to review the drug history in PDMP, which we already discussed how we're going to do that. And then we're just going to exercise caution when we're prescribing opioids and benzodiazepines, because we need to be aware of the drug interactions when prescribing any kind of drugs that may not work well together. This is again by the ADA. This is a statement on the use of opioids for treatment of dental pain, initially published in 2016. These are not updated, but again, I have spoken about pretty much all of the aspects on what the ADA wants us to do and knows are, regarding of responsibilities towards prescribing drug history, medical dental history, following CDC guidelines, using prescription drug monitoring programs, knowing when to consider opioids, using multimodal pain strategies. That's something that I haven't discussed before, so I'm just going to take a minute to talk about that. So with the multimodal pain strategies, it's more about using a combination of things to control pain. And that would include, for example, I could give a long-acting anesthetic, like a bupivacaine, and then combine it with NSAIDs. So I'm basically doing a combination so that I don't have to prescribe opioids. And then again, you need to coordinate with other physicians, healthcare providers, to be able to get the pain management. So this is the final slide that I have from the ADA, and this talks about how do we select pain management strategy based on the severity of pain. Again, 2016, this was first adopted. For mild pain, we're not, for mild to moderate and moderate to severe, we're not prescribing opioids. NSAIDs are effective. And for moderate to severe, we have a combination of ibuprofen and acetaminophen. Again, the first day, usually the pain is a little bit higher following the procedure. So again, we're having a very specific dosage on the first day, and then starting the second day or the third day, there is a change, and the patients can take it as needed, or every 6 hours. For severe pain, however, we do understand that the procedure will cause enough pain that we are prescribing an opioid. So we're still giving it in combination with ibuprofen, and we're prescribing a very small dose. And this hydrocodone 10 milligram, along with 650 milligram acetaminophen, plus we're prescribing ibuprofen. And we're only having introducing the patient to opioids for the first 2 days. So we are cutting down on the dosage, and we're cutting down on the duration of the time we're prescribing it for. And then again, going back to our ibuprofen acetaminophen combination after the first 2 days, if the patient is in severe pain. Again, if the patient complains of persistent pain after the time that you had estimated, you need to follow up with the patient and ask him or her to come and check back in at the office, because a lot of times they may be suffering from dry socket, and you need to have a different management strategy for that. All right, here are some of my resources from the ADA CDC, and I have some chairside pain management checklists, which you can access from the presentation. And that's about me. This is my information, and please feel free to reach out if you have any questions.
Thank you so much, Dr. Marwaha. Before we move on to the case presentation by Dr. Urankar, I wanted to open up the floor to see if anyone has any questions about the didactic or anything in general for Dr. Marwaha. Since we have about 15 minutes for the case, let's move on to the case. If Dr. Urankar, if you
Yes,
could
I will
share.
be moving the slides for
Thank
her.
you so much.
Of course. All right, the floor is all yours, Dr. Urankar.
Thank you, Dr. Marwaha, and I'm happy to present this case that happened at our health center not too long ago. You may see some of the stuff that Dr. Marwaha presented in her case. You will see some of those red flags coming up, and it'll be interesting. So, do we want to move the slide? Next. Okay, so this was a patient. Let me give you a little background of this patient. She was a walk-in patient, not an established patient at the center. A 32-year-old female patient that reports to the dental clinic. Her chief complaint was, I have extreme pain, 10 on 10, in the lower right tooth for 3 days, cannot sleep, eat, or perform any duties, perform any day-to-day functions or activities due to the pain. Her vitals were 78/59, pulse was 64. Medical history, there was no significant contributory medical history reported. Also, she had not been to her provider in a while. She did not have a designated primary care provider. In the dental history, she had root canals already in tooth number 29 and tooth number 30 with crowns, several missing teeth. Previous treatments were all done under sedation, and the patient reported that she has extreme dental anxiety. When we talked about the drug allergies, she was allergic to ibuprofen, she was allergic to aspirin, she was allergic to Tylenol, and anything that we could have prescribed for pain. So only thing she said that worked for her was hydrocodone, and that was something she was specifically asking for. So you can already see the first sign there. Next. So in the clinical examination and diagnosis, this tooth number 28 was discolored with deep caries on the buccal side. It was tender to percussion, palpation. It was not tender to percussion or palpation. There was no response to the vitality test. There was no periapical radiolucency. There was no signs of fever, swelling, or any enlarged lymph node, which could corroborate with her 10/10 pain scale. So this was the diagnosis of this case was the radiograph, as you can see, it does not show any periapical widening, or there was a little widening with a little chronic white line around it, which shows that this infection has been there for a long time, and it's chronic, so it's not eliciting any pain. The diagnosis was necrotic pulp. The treatment options offered to her, because she said that she was not interested in removing the tooth. She said she wanted to save the tooth. So we told her that we could try doing a root canal or a crown. And if that does not work, after we open up the tooth, extraction would be the next option. And then you can go in for a replacement with an implant or a bridge from 29 to 30. So you do not have that missing gap there. The patient requested, she wanted to get the tooth saved, and the procedures need to be completed under full sedation. So she was not open for any other option, no local anesthetic. She wanted everything done under full sedation. Next. So the treatment plan that we had proposed to her, as I already said, because she was extremely in pain and she was just going on asking for hydrocodone, or she said, if you cannot give hydrocodone, at least give me Tylenol 3 with codeine. It's going to really help me. So the treatment option that I offered her was immediate pulpectomy to relieve the pain. I told her you will not even need anything if we relieve. If we start open up the tooth, and then you can schedule an appointment to come back and complete the root canal. So she was not very happy about that. Instead, she saw she was going nowhere. So she said, you know what, just give me a referral and I will seek care outside because you all don't have sedation. So it was our fault. So looking at this patient behavior, she was pretty stubborn about getting medication for pain and sedation for dental treatment. On offering to start the treatment same day under nitrous, patient said that she does not have the money and nitrous does not work again for her. So she ended up getting a referral. So this happened at the clinic. Now, after 1 month, you have to remember this date, 4/13/2023. It's going to come up again. So after 1 month, what happened was this patient called a different location where I had not seen her to seek for a different provider. So this is again another second red flag. So 1 month later, she calls the dental clinic at a different site and specifically requests for Tylenol 3. This time it was not hydrocodone, it was Tylenol 3. She was offered an immediate appointment again for pulpectomy the very next day. And we said our scheduler will reach out to you and you'll get an appointment scheduled for root canal and you can come and we can help you. So when she reached out for that to make that appointment, she said that the tooth was already taken care of. So next slide, please. So why it was already taken care of, you can see in this PMDP aware profile. Look at where the date of 4/13/23 appears again. She got her acetaminophen and codeine combination. And of course, the doctor just gave her a limited combination, but it was not at our health center. This was a different doctor. So that taken care of was she went and got a medication that she needed from a different provider. So this is again another red flag, switching providers. So we see all these characteristic features in this patient. So now when you come across such a patient, how do you educate such a patient? These are my questions for Dr. Marwaha. I think some of which that she has already addressed through the education, but sometimes patients do not want to be educated. They just come with what they just come to the clinic deciding what they want, and if they don't get, they're deaf. They pay a deaf ear to you. Can you refuse to give a prescription if the patient insists on getting a prescription for opioid? And what alternative medications would you suggest? I think she's already addressed this. Any insight into a stubborn patient behavior? And any insight, if you have, Dr. Marwaha, into just refusing to give the tramadol? Of course, I think that comes in the second question, offer alternatives, which you've already discussed. So just some questions for you.
Sure,
Thank you.
I would be happy to address that. Insights on a stubborn patient. Although I understand that the patient was, having certain behaviors, I think this is when, as a dentist or as a healthcare provider, any provider, you need to understand that this is a red flag for you, right? I talked about some classic signs, and this case really was an exact display of those signs in one. So I think I would just notice those signs, and in this case, what can you potentially do is try to educate them on the efficacy, right? I spoke about that efficacy is, for opioids, it is actually they're not very efficacious when it comes to acute pain. Now, the patient clearly had drug-seeking behaviors. She initially came in, said she wanted a hydrocodone. She was allergic to Tylenol 3. And then she got a Tylenol 3 from another provider. If you go back and check the history, and I'm just going to move the slides because I want everybody to see, in 3 months, February to the final April month, she already had 4 prescriptions. If you look at the prescribers, they're all different names. And so this is very much, I would see a drug-seeking behavior, and I would obviously try to engage in educating the patient in terms of the efficacy of it. But what are you going to really say when a patient says they're allergic and that she was like, I started throwing up and this just does not work for me. So at that point, again, as I said, it is up to me if I would like to refuse the prescription. But again, I have to have a backing up for what I'm doing. And like you did, Dr. Rankar, I would definitely, if I see that was the situation, I would have gone ahead and scheduled for an appointment because the work needs to be done. But as you know, we've already discussed in the presentation that a lot of times they're like, no, I just need it for pain, and I just have pain. Now, I wish there was something made to measure people's pain, but there's no device like that so far. So we just have to believe our patients. But at that point, it is my decision, and based on my knowledge and what the licensing boards suggest, the ADA best practices, I would not prescribe. Yes, they are. She did get her prescription from somewhere else. And I would like to go back to one of my slides, which from the ADA actually, and they very specifically say here, ADA statement. Dentists who are practicing in good faith and who use professional judgment regarding prescription of opioids for the treatment of pain should not be held responsible for willful and deceptive behavior of patients who successfully obtain opioids for non-dental purposes. So this, I think, would be my answer to all of those questions.
Also, one more thing I noticed on that chart that we got from the Texas pharmacy.
Yes,
this one. She's gone to the same pharmacy. The pharmacy also could have caught this, that she's coming
Yes.
every time for an opioid prescription and with a new provider every time. So
yeah, and she said hydrocodone works for me before she came to you, and then when she was able to get the Tylenol 3, she was fine with that. Yeah, so that's just very, very straightforward.
And I feel that this patient was using that tooth. I want a root canal, although it was a non-restorable tooth.
Correct.
I want a root canal, do not want to, because once the tooth is gone, it's gone. Then she loses her chances of getting that medication.
Exactly.
So she's using that tooth to go shopping. Yep.
Right. I would again open it up to any questions our audience has for me or Dr. Rankar. And I'm going to stop sharing so we can interact better.
Thank you so much. Yes, as Dr. Marwaha mentioned, if you have any questions, type it in the chat or unmute and ask away.
Hello, can you hear me?
Yes.
Hi, this is Dr. Murphy.
Hi, Dr. Murphy.
Hi, and how are you, Dr. Mahava?
I'm good. I'm good.
Doing good there. I'm calling to thank both you and Dr. Urankar for your presentations. I think they're very relevant to today's dentistry. I'm from a period where it started out somewhere with a toothbrush and sugar bugs, but now our profile is very strongly into controlled substances, trying to identify, manage them, and if possible, to affect some change. One of your students from UT is here today, and he's asked the question before: how do we best affect behavior change? Which is a good question. But that is the kind of questions we are asking as we try to deliver new wave healthcare in today's world of these new substances, which are affecting the lives of a lot of people. But thank both of you for your presentations. Very relevant.
You're most welcome. And just to talk a little bit about behavior change, I mean, it is a significant aspect of public health and how we bring about change in people's behaviors. It obviously doesn't happen overnight. Behavior change is something that takes a long time, but education and awareness are the key to it, because people will make informed decisions at that point. So, yeah.
Thank you, Dr. Murphy. Any other questions? Maybe we have time for one more. Okay, all right. I see that it's almost 1. Thank you. Oh,
I do have a question.
Yeah.
So I know it said on the bottom of the guidelines about dentists not being held responsible, but what if a dentist, if a dentist sees on the drug monitoring site that there's been 4 call-ins in a short period of time and then calls in another prescription, is that, I don't know, looked at by whatever governing body would be involved with that, be looked at as maybe incorrect prescribing on the part of the dentist?
So we don't also know, Dr. Farrell, that if these were prescribed by dentists, because based on the PDMP, you don't know what it is prescribed for, right? Is that what you're talking about, or no?
Well, I'm curious as to whether or not it was prescribed for, say, a toothache or a fractured limb. I guess for me, if I were looking on the drug monitoring site and I saw but there were 2 prescriptions in February, 1 in March and 1 in April, I guess my question would be, would you investigate further, maybe ask the question about why those were prescribed to the patient? Like at the end of the day, how long could it go on for the dentist to not be responsible for yet another prescription for the narcotic or for the opioid?
Okay, so I think this is going more towards the legal aspect of it. I'm not sure if I would be able to answer that, but I think, to the best of my ability, I feel like as long as it is not justified to prescribe it and you cannot back it up with evidence, you should be okay. As long as you're able to justify your reasons that this is the reason I, did not prescribe, and I did understand based on the severity of pain and the causative agent for pain that an RCD was needed. If the patient canceled the appointment, what are you going to do about it as a provider? And that's a recurring pattern, right? So I guess best way is, accurate and adequate documentation. You always need to have your notes on point, whatever discussion you're having with your patients, whatever procedures you're planning, proposing, everything, all calls, all visits. I think you just need to have that as your backup.
Well, thank you for a wonderful presentation. I enjoyed it.
Thank you so much for listening in.
Thank you, Dr. Farrell, and thank you, Dr. Marwaha, Dr. Rankar, for your presentations. Please complete the post-session survey. The link should be in the chat. And if you would like to submit a case for the future sessions, please reach out to us. We hope to see you in 2 months for the next Dent Echo. Thank you for joining.
Thank you.
Thank you, everyone.